Hi, welcome to On Mind with Andrew Archer. Today we have Tammy Ulmen back in the studio here. She's a licensed marriage and family therapist, owner of Stepping Stones Mental Health Center, kind of specializing in trauma, but you work with people across the lifespan, kind of a generalist practice like we talked about. Last time I wanted to just start with something I pulled from your bio that you started really listening to others at an early age, and you were in a farming community, small town, right?
Yeah, I just feel like, elementary age, friends always coming in talking to me about their problems and even, other people, dating advice. So I kind of feel like I was, just meant to be in the field, but originally I planned on being a nurse. I didn't ever intend to be a therapist. So somewhere that goal kind of changed. But even today, people don't have to know I'm a therapist, and they just come up and they start telling me their
gravitate towards you.
Yeah.
Yeah, well, nursing, another profession where listening is really important. So today, one of the topics we wanted to get into was borderline personality disorder. Probably one of the most misunderstood diagnostic categories. So we can kind of talk about some of the symptoms, the criteria, misdiagnosis, but for kind of a layperson listening, can you kind of give an overview of what that looks like clinically, and I can kind of fill in any blanks?
Sure. So a borderline personality disorder is a fear of being abandoned. And that abandon can be real and it can be imagined. But basically, they will sometimes push extremes to test someone to see if they're going to stay with them and be loyal, but always fearing that people are going to leave them and they're not good enough.
Mm-hmm. And almost at times setting up situations to sabotage.
Correct. And I've actually that's one of the things I want to talk about is self-sabotage.
Yeah. And this is a chronic, pervasive, preoccupation with being abandoned, like you said. So it's really across the lifetime. And with personality disorders, they should not be diagnosed until 18 at least. And clinicians really want to have a bit of a long-term perspective with patients. I mean, because just kind of meeting the criteria, which we can kind of get into, doesn't necessarily mean that in that relational process there's this pervasive fear of abandonment, because the symptoms will overlap with things like we talked about last time, post-traumatic stress disorder. Not that the two can't be diagnosed at the same time, but you get patients that come to you where therapists have said that's what they're diagnosed with, or they're diagnosed with it very quickly. And I tend to not focus on it too much, but also be a little skeptical in terms of you really want that long arc of these issues, right?
Well, and I think I'm assuming you've been taught the same way, that looking at any kind of a personality disorder is not something that you would do rashly, that you want to take a look and make sure. They say sometimes it's like our spidey sense goes off when you meet with someone for the first couple of times and you sense like something's there, but I'm just not quite sure what it is. It's probably a personality disorder, but I'm going to explore it more. I don't typically diagnose it right away. As far as the being under 18, there are a few times I have with consultation, because it's been such a bad case, or they're close enough to the age of 18. But again, sometimes we get so caught up in a diagnosis, and a borderline personality disorder is not something you're treating with medication. I mean, it's strictly a therapy approach. It's a mind approach on how you're going to look at things, coping skills, things like that.
Well, with medication, it's often the shotgun effect, right? Where they just throw medications hoping something sticks. And I think that connects with some of the symptoms. Also, what's interesting is the personality disorder section in the DSM is one of the only sections that's really had staying power since the early origins of it in the, I think it's 1952 or something, that the first edition came out. Is that comes from psychoanalysis, really, a much more analytic approach. But some of the symptoms, I used to lecture about borderline personality disorder, so I kind of had like an AEIOUs of the in terms of the symptoms. So we have affect instability. So kind of like a light switch, people are sort of up and down or extreme.
Correct.
Feelings, emptiness, chronic sense of emptiness, no real sense of self often. And I want to say there's something like 8, you have to meet 8 of these criteria. The self-harm or very, kind of dangerous behavior, you have cutting, you can have substance abuse in there. Certainly suicide attempts is a tip off.
Some ideation, yeah.
Yep. And I think less commonly known, I'm probably missing a couple, but is the transient paranoia. And that goes to the original, title of it. Borderline is borderline of reality and psychosis. They're not really technically psychotic, but certainly the rational functioning, kind of like the ego that Freud talked about, reality testing is not there. So they can really look pretty close to psychotic, but not a psychotic disorder. Am I missing anything in there in terms of symptoms you can recall?
There was one that just came to my mind, but it left again. Poor sense of self.
There's often this mood component, depressive component with it.
Yeah, very much so.
The other thing is misdiagnosis. People will be diagnosed with bipolar disorder because you have that mood issue and almost the kind of psychotic or what looks like manic presentation. But with the bipolar disorder diagnosis, you have to have a manic episode. And with bipolar 2 disorder, you don't have to have that manic episode. So you often get somebody diagnosed with one of either bipolar 1 or bipolar 2, and it's like,
I often do see they coexist together. Yeah,
but it's kind of a gray line, if line, between the two. So you talked about, you don't necessarily diagnose it right away, but talk about your process, or more from a therapist perspective. It's kind of, you get a kind of pit in your stomach oftentimes based on very gamey behavior. That's what I've noticed.
Correct. And it's like almost being comfortable with chaos. And if there is no chaos, then I'm going to create some chaos because that's where I feel most comfortable.
Yeah. And the clinical presentation, often very provocational. So they might dress in a certain seductive way, or do things that are kind of irritating, habitually late to session, or canceling. That's not the criteria,
I haven't had so much, but
or oftentimes real meticulously on time, because there is this big gap between kind of the emotional version of them, the little version, and the rational, analytical. They're just two different, widely different presentations.
Yeah, I would definitely agree with that. Usually, I guess I haven't had it where it's been not being appointments. It's usually I'm not going to miss an appointment. I remember at one point a particularly difficult patient, and I felt we were kind of stagnant, and there was some boundary violations, which I'll talk about in a little bit, where I kind of had to say that, this isn't okay. That I said, I talked with some of the other people in the care team, and I think we're going to take a couple weeks off from therapy. I feel like we each need a new perspective. And the person became pretty destructive. Because I live in such a small community of 2,300 people. The person knew one of my friends. They went to their employer at the school, made up a story. Tammy this person said this and this and this to Tammy and breached confidentiality about my child, made up this story. It became pretty traumatic for me because this person regularly tried to insert themselves into my life. And it's really hard to do when you're in a small community of trying to be invisible, really. But because I had said I was going to take that couple-week break from therapy, she feared that as abandonment.
Right.
So we created a bunch of chaos to deal with it. And we were obviously able to recover from it and talk about it and move forward. But for me as the therapist, it's constantly making sure that those boundaries are really firm.
What other boundaries do you put in place or think about?
They tend to find out where I live. I had one of my patients actually show up for a town parade and sit in my front yard. I was very uncomfortable about it. And then they kept turning around trying to engage and talk with myself and my family. Social media. And I think that's every therapist, we have to set a boundary around our social media and our private life. And this particular patient I just saw the other day found one of my social medias, TikTok, and it sent me a notification. This person viewed your profile. And I'm just like, it becomes really frustrating. So it's the constant reiterating of those boundaries, and not only boundaries with myself, but with other people as well, and themselves.
Yeah, because like you said, if there aren't those boundaries, then that's the way to chaos, which you're used to. We should add, these self-destructive behaviors that is so integral to that presentation. I've never met a patient that kind of meets the criteria that hasn't had trauma in their history.
I would agree.
Right?
Yeah.
And so the one characteristic of PTSD is that kind of hyperarousal. So that's that familiar feeling that they're actually setting up interpersonally. I'm thinking of a patient now where I asked them, what are you expecting to have happen here in therapy? What do you want to get out of it? But what is kind of going in your head, especially about stopping therapy? And they think, well, you're going to be mad at me and get rid of me. That's right.
That is true. Yeah. Yeah. And I always tell patients, I just had this conversation with a patient a couple weeks ago, as a matter of fact, that I'm not going to be in your life forever. The goal is to get you the support from people around you and you to have the coping skills that you can deal with these situations yourself and that you won't need me. But that often is very frightening for them. They become so reliant. So again, that's another boundary setting. I'm going to be here for you, but I'm your therapist. I'm not your friend. I'm not your family member.
Yeah.
We meet once a week and, we have an hour together.
Yeah, you want to build that dependency into your relationship, like with any patient early on in therapy. But the expectation is that environmental support that we provide is going to slowly go away. More self-support. And with that, I've been asking not just people that present with those symptoms, but everyone is, what do you expect of yourself, in terms of goals and therapy, rather than me telling you, here's how you need to be healthy. What you should do is, what do you expect of yourself? There's a game that Eric Byrne talks about in the book Games People Play. It's kind of underneath the heading of what he just calls psychiatry, is what he noticed a lot of people just coming into therapy and sort of talking about what's going on in their head or using sophisticated jargon to talk about their symptoms, their illness, but staying stuck and not, improving or making progress. And he called this wooden leg, is like, what do you expect of me? I have borderline personality disorder or bipolar disorder. Is like, I have a wooden leg, a disability. And he said, in the book, it's like, I expect you to steer your own wheelchair if you have a wooden leg. There's people with no legs that learn how to dance and can swim with no arms. So it's like, I don't have, and I think that's often an issue, is they'll just basically say I'm crazy or present in sort of crazy ways and not setting up a solid contract. So you have to really go back to, what do you expect of yourself? Because a lot of what it looks like is, as the patient, I'm going to try and get you to not like me and get rid of me. They're not necessarily conscious that they're doing that, and you can't just convince them like, no, I really like you, or disguise it if you don't like them. It's like, because they're like I said, there's a lot of games being played there, and I think the main one is this kind of kick me, is they set up provocations to get you to kick them, which could mean referring them, or like that example, like taking a couple weeks off of therapy. They perceive that as, oh, she hates me, she wants to get rid of me, she's going to refer me, not recognizing that, okay, what are you doing to set that up?
Right. Right. So it's something that you had said too, with the alternating extremes of, I love you, I hate you, I love you, I hate you, and not quite sure where that's going to play out today. Do I like you today, or do I hate you today? Becomes really hard. And that becomes really hard in therapy, especially because if they're going through a phase of, I really hate my therapist, I'm going to go home and I'm going to be really, really pissed off at them because I don't like what they told me today. I'm not going back, but they come back again the next week. But that's really hard sometimes to work with. I mean, I can handle you're upset with me. I'm not here to be your friend. I'm here to help you notice things in your life that aren't working so well for you, and to try and move past them. Yeah.
And that's one of the symptom criteria we missed. Idealization and devaluing is like, so they say to you, oh, you're the best therapist in the world. And then they go see their psychiatrist, and that Tammy Ulmen is the worst, right? And so they kind of triangulate things to devalue over here. But you'll hear that in the language, very strong kind of dichotomies. Oh, my mother was perfect, my dad was evil. These big. Did you have more to add about that?
It happens so often that. And I can't say that it hasn't happened with a patient that I have had yet with borderline personality disorder. I think it's one of the main criteria that I see, along with the unstable mood. So, and maybe, does that tie in together, the ideation and the devaluation, when you're looking at, well, what's my mood today? What's my perception?
How you describe it.
Yeah.
Yeah, that is kind of an issue in general with the DSM. Is based on self-report largely. I mean, there's the clinical, observation of the patient, but if they're describing things, not very objectively, or they're making them up, we don't know the difference. the checklists certainly don't know the difference, right?
No, but as you get to know the patient, you start to learn, they're not being truthful. So particular patient, again, that sat in my yard in the social media stuff. So my son was in a local golf tournament, and he won the tournament, and pictures were posted of, these are the people that won this golf tournament. And this person had never golfed in their life, never even been to the golf course, and went on and made a comment and congratulated my son. And I had already had a lot of conversations about, I'm not going to be your friend on social media. I'm not your friend in general. But I really had to have an in-depth conversation about how invasive that was for me. And please don't do that again. To which she told me, and she spent a lot of time on the internet, to the point that there were a lot of parenting issues that were going on as well, because she was so absorbed into social media and there was no care being provided to the children. So the rest of the care team, we were offering suggestions on, maybe you should limit your social media use. Maybe you only, while the kids are in school, you're on social media. Maybe you only do it for 3 hours a day. The goal is we want you to engage more with your children, play games with your children, get out and do things with the children. So it was all in the conversation, the part of this conversation about that, that this happened. And so, I'm offering suggestions. The county case manager is offering suggestions. So she tells me, I got rid of my social media. Yeah, no. She blocked. She just blocked so I couldn't see comments. And it's like, okay, I never addressed it. It's like, well, you know, you're trying to be deceptive here again, but yeah.
A little bit of sort of hide and seek going on there.
Yes. And, you know, another part of my concern is like KEYC, you know, has a Facebook page and they're posting updates. And she was constantly on there making comments. And I asked, well, what do you get out of that? What purpose does that serve for you? Do you know any of those people? Well, no. So what is the purpose of you commenting? Well, I want to be a good person. So let's backtrack a little bit. You know, where we want you to work on these skills with parenting. So let's work on being a better parent and being more present for your children instead of being present for people that you don't know that are in the greater, you know, Mankato area. Let's look at that in a little different lens and see how that impacts your life. The validation, needing validation from other people. So that one of the other criteria that, you know, the creating the chaos. So when we have a problem in our life, we're going to go to social media and we're going to blast it out because we want everybody to know what someone did
sort
to
of
us.
Megaphone to do that, yeah.
And again, I'm saying, okay, what are you hoping to accomplish by that? When you went to this business and you told this business the problems that you were having in your marriage, what did they do for you? They stared at me. Well, did they offer any help? No. Do you talk to them any other time? No. So they're not in your friend group. So again, what is the purpose? Well, because I need someone to hear me. Well, is that the right group of people that you want to hear you? You know, I understand we all want to be heard and validated, but are you getting that?
Well, that seems to be the crux of the issue clinically, certainly where I've gotten sucked in is, you know, asking, well, what is your motivation to be doing these behaviors? And they could say, well, I'm trying to be a good person or something like that, but I don't think they understand because it's this childlike behavior. You know,
very much.
I don't use the criteria necessarily with people, but it's like, how did this show up when you were little? I mean, of course, a parent abandoned them, for example, or, you know, they were removed from the family, they were foster care. And so, you know, looking at it more from a game analysis perspective, okay, I'm going to provoke the therapist by, you know, looking at your social media stuff or commenting in public with something that's private. And then we end up, because I think we get hooked into, we want to help people. That's our kind of weakness, is like seeking out, why did you do this? Or what was going on? And they can make up a story kind of rationally, but that's actually not what's driving it. It's this affective part of them. And so it really just seems to me, that's how I think about this extreme, you know, the analytical part of them, you know, can make it to the appointment on time, for example. But this childlike part of them will set up these provocations and things. Like I had early in my career when I was practicing in New Hampshire, a person presented and they said that they had cut themselves on their face with a knife. And, you know, I'm this green pre-licensed psychotherapist. What do I do with it? You know, I consulted and stuff with a clinical director, but that's obviously a provocation. And then why are they telling me? Well, it's like you were saying before, there's this push-pull, like I'm going to get really close to you and then get the hell away from me kind of a presentation. But that's just the two very extreme different parts of them. So I think when I mentioned hide and seek, it's like they'll do things or kind of hide things and then hook us into seeking out, you know, what were you doing? But that just allows them to kind of back away, you know, or again, the devalue, okay, my therapist is being mean to me, or, you know, they kind of split, the splitting with other.
Tammy was really crabby today.
So I think that's where I've ran into trouble. Is another game that Byrne had was called I'm Only Trying to Help You. Is like, you know, the kind of payoff is that for the therapist is like, this person isn't following any of the boundaries, like you're saying, or the treatment plan, the goals. And so you can kind of throw up your hands. That's kind of the punchline. I'm only trying to help you. You know, the therapist gets very frustrated. But that, I think, you know, going back to that example of the wooden leg, is if we're seeking them and telling them, here, do these things, and they don't do it, it's like, but then you step back, it's like, why am I doing that? Well, it's usually fear. I mean, when people bring up borderline personality disorder in consultation, oftentimes the label isn't so much intellectual. They're just like, this person is kind of driving me crazy or something. And so that I think feeds into it almost. You can distance yourself. This person's borderline. And so there's nothing I can do about it, right? It's kind of like a hopeless case, but I'm sure you've had successes with people with, because you've seen a lot of people with this presentation.
I have, but I can't say that we've ever ended treatment. I feel like it's almost a lifelong, you don't necessarily like to give that prognosis, but usually people with a borderline personality do have a really poor prognosis. It's a lot of hard work. I mean, they have to want to dig in, and it's a constant daily work. Again, like, I said before, there's not a medication that can't fix it. It's all therapy. It's all how you view things, the changes that you're able to make, the skills that you're able to use. So it's not been my experience yet that I've been able to terminate end treatment with anybody because they're healthy enough to be on their own.
And the focus I take is understanding their personality structure. You can call it borderline personality disorder, but getting them to see these vastly different parts of them that are extreme. Like there used to be that multiple personality disorder in the DSM, which they changed it. But that's just an extreme version. People with that, they don't remember things because they're in this different state of mind. And so I focus on mindfulness and meditation, getting them to orient back to objective reality. Like describing somebody is either, a saint or the devil, that extreme is like, well, what's actually happening? What do you actually feel in your body? What's going on? I mean, that's the other, I don't know if it's part of the symptom criteria, but the dissociation and depersonalization that comes
Dissociation, that's another one of the criteria.
So that is in the criteria. Yeah. So being basically out of your body, and DBT is one thing. Do you have somebody that, or groups in your area, Adelia?
No, usually they have to come to Mankato.
Mankato, yeah.
Yeah. And DBT is a very extensive program.
Right. It's a group format. It's more of a kind of classroom setting.
I've not ever done it, but I mean, just from what I've heard from, other therapists and some of my patients that have been in DBT groups where they alternate with doing individual therapy and group therapy, is some of the group therapy helps them holds the person accountable, that when they do these things that they can be like, well, wait, why did you do that? What were you thinking? And sometimes hearing that from a peer can be more helpful than hearing that from a professional.
Yeah, right. So what are the backgrounds you see in terms of this clinical presentation? Are there commonalities in terms of upbringing, childhood?
It's funny that you say that, because I always wondered, that nature versus nurture thing. I actually took a course on, it was the cluster that borderline personality disorder is in. So I think it was borderline, avoidant, a few things. I went up to the Metro, and it was a nationally known speaker. And that was the first time, I think a lot of times you're just conditioned to think that this is learned behavior. That was the first time that I was actually educated that it's actually an inherited behavior. It's in their DNA. It can be passed by DNA. So I don't know how much of that is true. But I can say in the cases that I've worked with, it always starts with the trauma. There's trauma all the time, at the base of it. And, a lot of times, so I made some notes about, looking at reactive attachment disorder in children and the two types, the inhibited versus the disinhibited, and how that impacts, I would love to see more research on how often the reactive attachment does morph into the borderline. It just continues on.
Right.
So I don't know. I definitely think a lot of it is the environment, that it's environmental. I can't say that I have had a patient, I would love for somebody to show me differently, that hasn't had some kind of childhood trauma.
And a lot of times scapegoated in the family, like they're
Oh,
the
very,
identified
yep.
problem.
Yep.
And people might not understand what that means. Can you explain that a little
So
bit?
blaming one person, so you have a family that's not functioning very well, and there has to be somebody to blame. So we're going to choose this person, and everything's going to be their fault.
Yeah. And, going back, what I was mentioning in terms of hide and seek, with that trauma, oftentimes it's not disclosed to anybody in the family or much later after it happened. And getting into, like you were saying, the parenting, some of the stuff that I've heard, it's like, where were the parents? Like,
Yeah.
what planet were you living on that you didn't have any sense? I mean, the person is trichotillomania, pulling out their hair,
Yeah.
cutting themselves, and I've heard stories, multiple stories from different people where one of the parents, after they've discovered that they're cutting, well, then what's their response? Well, they strip them down at night and check for cuts, as if that's going to be real therapeutic for the individual. Then they just hide by cutting underneath their feet or something.
Well, and I probably
like that.
take a little bit of a different view on cutting. I always ask what do you get out of cutting? Are you doing it because you feel dead and you want to feel alive? Is it because you like the sight of blood? It reminds you that you're alive. Do you feel like you're a bad person and you deserve to be hurt like this? What is your reason for cutting? But I don't usually get too concerned about cutting unless I see it and they're not telling me. I get more worried about the people that don't talk about the cutting or hiding it and doing it places. If I can see it and they're showing it, I feel like, they're expressing, I'm really hurt and I want
Yeah.
you to know this,
Right.
but I'm not intending to kill myself. I feel like they're more discreet. That's just been my experience.
Yeah. And I see it, or I'll ask similar questions too. What is just like any kind of mind altering thing, it's usually a way to ground oneself, feel pain rather than emotional pain. And so I'll just be, what do you get out of this substance or the cutting or gambling, whatever it is? How does that sort of work for you? What's the advantage? I think oftentimes with the self-harm, burning, cutting, any number of things, it's a passive way to elicit help. So whether their boyfriend notices it or their mom notices it, and in violence, whether it's against somebody or on yourself, it's you're giving up any responsibility of solving the problem. So let's say past trauma is coming up for them, or their girlfriend leaves the person, and so they can't deal with those emotions, and then they cut. Like, that's not dealing with the problem.
No.
It's sucking other people in to kind of take
Correct.
care of them. Right?
Yeah. Yeah, agree.
What else do we want to say about, borderline personality disorder? We've covered a lot of bases. It's often misdiagnosed. It's certainly diagnosed too quickly, and usually from just inexperienced practitioners. The better psychiatrists I've worked with have said things like, well, I won't diagnose it for a year because I really want to get a sense. Is it something else, like
Right.
bipolar disorder and things?
Yeah.
But that presentation, because it elicits so much fear, it can be really difficult to, this is the whole point, to get close to them and to really like them and see them, because all you see is the self-destructive part of them. Maybe some intellectual aspects, but I just see a lot of deception and manipulating that they're not that they know they're doing that. I don't get mad.
I think they
sometimes
I think some of them do, and I think it's deliberate. I don't want this person to see me this way, because if they see me this way, they're not going to like me. So I need to present myself in this particular way, or I need to make this situation look better for me. So I'm going to do this and do this and do this so that it does make me look better.
Yeah.
So yeah, a lot of manipulation, impulsivity. You pause, think about it. Don't make any rash decisions when you're feeling like that. And this becomes even more complicated if they do have the diagnosis of bipolar as well. So then are they in a manic phase, or is this a borderline thing? Just practice the pause. Let's just take a
Yeah.
minute. Let's give ourselves 24 hours before we make a decision like that. Or you're really angry about something. I understand that. You have every right to be upset. You're right. That was an injustice. But before you react and do something that may not have a good outcome, let's think about it. What are your options? How can you handle that in a better manner that's going to be better received by the person that you want to hear it, and not just being impulsive.
Yeah.
Spending. Don't go out and spend your whole tax rebate check in one trip to Walmart. Let's put it aside, save it for an emergency.
All that self-regulation stuff. We had Devin Thorson on here. She's a clinician at Welcome Manor, so working exclusively with women, trauma, substance abuse. The impulsivity made me think of the marshmallow experiment, if you're familiar with that. With kids, you give them a marshmallow and you say, okay, if you don't eat this, if you wait until we come back in, then we'll give you 2 marshmallows or pretzels or whatever the treat is. And there's all these outcomes correlated with it. The people that are able to delay gratification, not be impulsive and eat it, all kinds of things like going to college, work, marriage, a bunch of different criteria. But with that impulsivity, like you're saying, spending, or I feel like anecdotally it's shoplifting is really common, and that would get at that kind of impulsivity. And so going back to treatment, so mindfulness, aware, when you want something, you feel it in your body, you feel some activation of emotion. And so what is going on there? Are you getting triggered? That's another thing we didn't talk about, is dealing with triggers. And so that's mindful awareness. And so when I think about that borderline kind of presentation, I pull on Eric Burns' view, which is you got to get them back to reality, keep orienting them back. That's basically just a structural analysis. What's going on in your head and your body in terms of grounding, because you can kind of ground yourself with something like cutting or cocaine or whatever, but being able to self-regulate. And I think, like we're talking about, if that attachment is disrupted when you're a kid, like how many, parents of these people that we're thinking of, their mom laid in bed all day because they were depressed. So no attachment, or they didn't nurse the baby. So that self-regulation stuff is really established birth to about 6 years old. And you throw trauma in there, neglect. I mean, people don't realize neglect is oftentimes worse psychologically than having a parent that hits you, for example, because at least they care about you. And so I think one thing we talked about last time was EMDR, that approach, and in that the core cognitions or core beliefs. I haven't met somebody with that presentation that says I'm lovable and I'm a good person. It's like I'm a bad person. I'm to blame for things.
If they're narcissistic, you might.
Yeah, right.
But yeah, you're right.
Yeah.
Otherwise, you wouldn't be coming to therapy.
Yeah. So anything else you want to add in terms of treatment or?
Well, it is. It's a lot of. I kind of like the CBT approach. I keep a dry erase board right next to my desk with, the triangle of, your thoughts are going to impact your feelings, and that's going to impact your actions. So, trying to make awareness, or where do you first feel when you start to feel really icky? Where do you feel that in your body? Pay attention to that. Then we can stop before you get into a fight or flight kind of situation. Recognize that, do a grounding technique. Interestingly, when you talked about mindfulness, I remember with a particular patient, I tried to utilize tapping. And she looked at me and she goes, "That is the stupidest thing I've ever seen." And I'm like, well, there's psychological, there's evidence, there's medical evidence that proves this, that you can confuse your brain. When you are feeling very, very anxious about something, you can distract your brain by confusing it by doing these different things and engaging both the left side.
The meridian systems or tapping.
So the one that I use, it starts off with tapping 5 to 10 times here.
Yeah.
And then the side of the cheek, the top of your wrist, the side, the top, rolling your eyes around in each direction, singing a song like Twinkle, Twinkle, Little Star, doing that. So you've engaged both sides of the brain, and it's supposed to just kind of push it out where the brain is confused. I used to work with a really good neuropsych guy, and he taught me a lot of tools.
Yeah, so not a whole lot different from the eye movement stuff.
Yeah.
I mean, you're orienting to what's going on
I can't
right
say
now.
that I've ever used, I mean, I've used the EMDR to treat the trauma part, but I guess I've never considered that in relation to borderline personality, but it's because I'm treating the trauma that's underneath.
Yeah. Oh, and before we go, we have, I don't know if we did this the last time you were here, but we have a little segment called Burn After Reading. And so these are questions from Eric Byrne. He has some interesting kind of assessment questions.
Okay.
And so I'm just going to have you pick one of the sheets of paper at random. So you're going to read it, and you can answer that. You can not answer it, which is an
Okay.
answer. I can answer the question, but just kind of, you know.
So the
something a little
first
fun.
one is, who chose your name?
Oh, yeah.
Actually, my father did. Who are you named after? Tammy Wynette. She was very popular back at that time.
What is she known for?
She was a country music singer.
Oh, okay.
And
Is that why your dad picked it? Because of her?
Yeah, so I grew up, and I do it today, actually. I did it this morning with my dog. I make up these silly little songs and sing, you know, like you do to your children when they're younger.
I just neglect my kids. I don't talk to them at all.
So
No interaction.
I grew up with my dad always going around singing songs. So that's some of my fond memories until my parents divorced when I was 7. So that is childhood for me, is hearing people singing songs. And I used to sing a lot of country songs. So I do that. I just sing stupid songs.
Did you get into music as a kid or high school?
Music is my coping skill.
Yeah.
If I were in a different life, I would be Joan Jett. I would love to be Joan Jett.
Yeah. Yeah.
Get him nodded. So yes, music is my thing. So.
Yeah. So these are script questions, meaning trying to figure out people's kind of life plan. And so your name and the connection with the country singer and, you know, probably a closeness, a fondness of your father, that there's no way you could know anything about that as a little infant, even as a baby.
No.
But people
It's a
do
sharing of
things.
stories.
Yeah. Yeah. And so for me, the name kind of unravels a bit too. I'm pretty sure all of my siblings, including myself, there's 4 total of us, it's a reference to the Bible, biblical, because I remember having a plaque nameplate on the wall that said Andrew, and it was something like strong and manly or something, which is kind of funny now because that's not really my orientation. But so then that points to, I mean, much if I was in a psychotherapy relationship, we'd be talking about Christianity and Catholicism and what that was like as a kid and how I kind of rebelled against it. But so the seeds of that are right there. And you wouldn't necessarily know that, like about your background with music and things without these questions, because it really gets at a less kind of intellectual process, more like what were you like when you were little and what was important, country music, Catholicism, these different things. So thank you for giving that a go.
Yeah.
And we'll have you back soon. This is Tammy Ulmen, Stepping Stones out of Madelia, Minnesota. Thanks so much for tuning in.